Hello, everybody. Welcome to MHTV. We're going to be looking at substance use, particularly in terms of nursing education today, and I hope that you can find it useful. We really want to hear from you. So before we introduce our fantastic guest, let me go over now to Dave, and he can tell you how you can join in. Dave?
Yeah, hi everyone. Great to be here tonight. There's a few different ways you can join in. The best way is on Facebook Live. If you just want to add your comments or questions into the chat on the side, and I'll bring in any comments that people post. The other two options we've got is if you're still sticking with X, if you use the hashtag MHTV, we will see it and bring in the conversation from there as well. But we're also on Blue Sky. So again, use the hashtag MHTV and we'll be looking there as well. Back to you, Nicky.
We're everywhere. So let's go over to our guest now, Dr. Natalie Finch. Can you tell us a little bit about yourself, Natalie?
Yeah, of course. So, Nicky, I'm not a doctor. I'll just start off with saying not quite there yet. I'm actually registered mental health nurse by background, currently working as an assistant professor at the University of Bradford. I lead on mental health in our curriculum, and one of my other jobs is I look after admissions to all the nursing programmes. So really, really interested in undergraduate nurse education.
Yeah. So can you tell us a little bit about your clinical background, sort of why this subject is such an important kind of aspect of your work?
Yeah, sure. So my clinical background is in working with people who have serious mental illness, but who are also struggling with challenges around addiction. So quite a complex group of clients. Really love that work, really rewarding, really challenging. Increasingly, because the NHS has lost a lot of the drug services, it's increasingly specialised work, and there are fewer and fewer of us doing that kind of work. But yeah, so that's where my clinical background is. And what I noticed when I was working clinically is we'd obviously take a lot of students. We had, that revolving door of students almost most of the time. And what we would see actually is that students were very enthusiastic on the whole and very keen to learn, but came to us regardless of the place in their studies, whether it was first year or third year, with virtually no kind of knowledge, background, training, education around substance use, alcohol use, and how we might work with that as mental health nurses. And that really struck me actually when I was working clinically, that so much of our workforce knew so little about what can be such a problem for our patient group.
I think you're right about this concern about there being little in the curriculum really to promote people to learn about this area as well. I wonder if you could say a little bit about that.
Yeah, absolutely. So kind of that was my experience in practice, and then when I moved into education, I thought, well, I can kind of look at this from a different lens now. Was that just the trust where I was working, or is it the same in the new trust where I'm now providing education? And actually, yes, it's very patchy. So in terms of the NMC future standards that we use to plan curriculums, it says actually very little about drug or alcohol use in there. And in fact, the only time it's overtly mentioned is to say that nurses should be able to discuss the impact of substance use and alcohol. And that's the one place that it pops up as an actual kind of, let's label it, let's name it for what it is, which seems to me to be, it's insufficient when we kind of look at what the data tells us around people who are using drug and alcohol treatment services. I think, we find that around 75% of people who are using those services self-report that they have a mental health treatment need. So really common for people who are experiencing mental health problems to be experiencing some use of substance, be it problematic or, in whatever means they might be using substances. It's there, it's present. Our workforce need to know how to do that. And yet the standards say so little about it. Equally, if you take a look at the Annex B requirements around procedures and skills, there's stuff in there about knowing how to perform CPR, obviously, responding to seizures, responding to anaphylaxis, your basic, first aid kind of scenarios. And there's nothing in there about responding to overdoses, which is kind of a life or death situation in the same way that a seizure or anaphylaxis might be. So it's it's obvious by its omission in the curriculum, in what the regulator requires of us. And in my experience at my own institution, but speaking to colleagues around the country, whether or not you have much or indeed any content around substance use, whatever that means, and we can kind of maybe unpick what we mean by that a little bit further, but it very much depends on, do you have a lecturer who's interested in it? And that's what drives it into a curriculum or not. Definitely. And my concern is that as fewer and fewer of us have that clinical specialism, because there are fewer and fewer NHS nurses working in that area, that what that means is it doesn't kind of have that trickle down into our curriculums.
Yeah, I definitely think you're right on that. So with that in mind, what is it you would like maybe student nurses to know about addiction, for example? What are they missing at the moment?
Yeah, so I think it's thinking in a much more nuanced way about substance use right across the board, really. So, you know, lots of students, quite understandably, hear the word drugs, for example, and because of the media narrative around drug use, they think that the only answer should be, you mustn't take drugs. Okay. And what we know is that's the most effective way of talking to people about substance use, you know,
because it's never worked. It still doesn't.
We'll never stop people from taking substances. You know, people have been altering their mood since the history of time with substances, and I'm fairly certain they will forevermore. So students are conditioned by their environment, often, not always, but often, to think that the only professional response to any disclosure of drug use is to say, oh, you mustn't do that. And actually, we want students to be able to have much calmer, more probing, curious discussions around substance use. You know, lots of people, contrary to what the media would have us believe, will use substances non-problematically. That is the vast majority of people who use substances. And so what we want our student nurses to be able to do in that space is to be able to give really good harm reduction advice. So how do you keep people safe, particularly when you're having conversations with young people? How do you create spaces where people are able to have open and honest conversations with you around this subject? Those are the kind of skills we need our nurses to know. We need them to understand, you know, what's the interplay between somebody's mental health problem and someone's substance use. You know, are they using it as a coping mechanism? Does it have a function? You know, and to kind of be curious about understanding what's the function of this substance in this person's life, because actually that's how we can start to work with them in an effective way as a mental health practitioner. So that's the kind of nuanced skillfulness that we really need to encourage in our nurses, and it's just not there.
I think there's such a lot of fear, isn't there? There's such a lot of fear, and it shuts down curiosity, because a lot of people have the skills to understand, what do you communicate in this behaviour? What's the need? They know how to ask those questions, but they almost feel like they don't have permission, maybe? Because they don't want to say the wrong thing or use the wrong terminology. So is there preferred terminology? Because we get a lot of this kind of like illicit substances, you know, which makes them sound super sexy. I always find that such a weird way of putting it.
It's so interesting, isn't it? And there are kinds of good language guides, you know, particularly around using non-stigmatizing language. But different communities will use different terminology. So as a practitioner, I would absolutely stay away from something being, you know, dirty or being clean. But there are lots of drug using communities who would happily use those labels themselves. So for me, it's always been about kind of taking the lead from who I'm speaking to, you know, taking their lead, and checking out with the person. It's not all right with you. Anonymous will refer to themselves as addicts. I probably wouldn't use that word. So language is difficult, but I think if you go into it with that kind of wanting to understand and being willing to make a mistake, almost, people are really forgiving if you do that.
And respectful as well, because you can say the wrong thing and apologise and say, "Oh, that was clumsy. What I'm trying to understand is this," and you can. It's fine.
Absolutely.
People will help you.
Absolutely. I mean, that's a wider conversation that I have with the student nurses I work with all the time. Yes, we get things wrong sometimes, and it's really good to acknowledge when we get them wrong. It shows we're listening, it shows we're interested in engaging in where you are. So yes, so the language is one thing, but then I think the other side of it is kind of the legality side of substance use, that nurses perhaps feel afraid to be seen to be endorsing drug use if they don't go down the line of saying you must not do this. So it's about how do we support people to have these really, thoughtful, curious conversations, which, holds different truths within it. So yes, we can know that perhaps not using drugs is the best option, but for some people that's not going to be an option. So then what's the safer option, and so it's teaching our people to have those conversations. I think is so absent. But I think you're right, it's fear, and it's fear of getting it wrong. But sometimes, getting it wrong can have really serious consequences. I talked to one student nurse, I remember, on placement, and he'd gone and spoken to a chap who was drinking really heavily, and he'd said, just stop, just for today, just try and stop. And obviously that's really dangerous. And he thought he was doing the right thing, that was coming from a really good place, because he didn't have the education to understand why that's potentially a really unsafe thing to do. We're making these recommendations that we think are from a good place, but are actually just not evidence-based.
We all winced when you said that, because obviously we know why that's a bad thing. But could you just explain to anyone who's maybe not had a long time in nursing why it's a problem to tell someone to just stop drinking?
So we would never ever do that, because it can induce seizures in people, is kind of the long and short of that discussion. So it's just not a safe and recommended thing to do. So we would always look at either a managed reduction or a proper medical detox, various ways of doing it, but we would never tell somebody to stop drinking abruptly. It's really dangerous for people. So it's that kind of stuff that's missing.
And when we don't feel like out, people do things like watch TV shows or films. When people do go cold turkey and stuff like that, none of that is health recommended. It's maybe makes for high stakes television, but it makes for really dangerous care. So please don't do anything like that. I know we don't need to tell you, like, don't watch the television for clinical guidance, but I mean, you do see it such a lot, and I can understand.
Yeah, of course, because again, that's what we see in the media around us. That's how it is. And very much the same when we kind of, look at understandings of addiction, and that's been something that I've spent a lot of time concentrating on with students, because there is very much still this kind of narrative around, that this is a moral thing, that this is, about people get better when their character improves and they're able to do the right thing and resist, and they make the right choices instead of the wrong choices. And this moral theory of addiction is completely debunked in all the literature. There's no basis for it whatsoever. This is not about moral choices whatsoever, but that's what we are conditioned to believe, that people were doing wonderful things. Life's not like that. Addiction's definitely not like that. So again, it's about helping students to understand, well, what might be happening when people start to use substances in a problematic way, and how can we think about that? How might we explore that with people that we work with? Because I think there's just such a moral imperative that we get this right. When you look at kind of the data that's freely out there, so year on year overdose deaths are rising. It's a crisis. Undoubtedly, we have a crisis of overdose-related deaths. Ketamine use is going through the roof in our young people. We're seeing people with terrible problems related to ketamine. Alcohol-related deaths are rising year on year. Alcohol-related admissions to hospital rise year on year. So these are things that they're not niche, as we would be led to believe. Working with drugs and alcohol is not niche. It will not be limited. Everyone will see it in their practice, wherever they are. It's not a side bit. It's often right at the core of the problem. So we all need to know how to work effectively in these spaces.
Absolutely. You said you said loads of things that are really important. Let me just wheel back to some of them. So one of the things you were talking about is this kind of like overlay of kind of religious or morality over the top of illness experiences. And you
Yeah.
sometimes see it in things like recovery from cancer. If you try hard enough, you'll get, that's not in the guidance.
No.
And it's the same thing with this idea that you can make a choice, and that
Yeah.
there's a weakness of character involved in
Yeah.
becoming addicted to substances, instead of seeing somebody as almost like a victim of that experience and somebody who's worthy of support and respect and compassion. Do you think maybe there's an aspect of fear, like if it only happens to bad people, then it won't happen to me, rather than the fact actually anyone of any age can get a problematic relationship with a substance?
Oh yeah, absolutely. And I do think that's some of what happens there as well, but it's almost protective, isn't it, to other people?
Yeah.
That's something that happens to other people, not to me, not to my family. But interestingly, some research I've recently done myself suggests that's not the case, and actually lots of student nurses do have experience of people very close to them having problems with substance use. So I think it's almost hidden and buried underneath, and people are fearful because, gosh, if I start unpicking this, what does it mean for the people I know and people I love? How do I separate myself out from that? Because I'm a nurse, so that can't be anything about me. When actually this is something that could happen to any of us, So
and you're
so
right,
there
I
is
think
still...
Sorry, go on.
No.
I was just getting very into what you were saying. I'm sorry. I went advice to listen more. And there was this, you were saying about it being hidden, but I think sometimes it's so in plain sight it becomes invisible. And I mean, like, nursing's had a problematic relationship with alcohol since like old staff clubs have existed. It's absolutely embedded culturally, and in fact, it's only, I think, in the last few generations of nurses coming through, but it's much less that case. Anybody who was sort of brought up through that kind of old asylum system or works nights out and that kind of stuff, I think had to deal with a really big
very much
culture.
ingrained.
And this idea that drugs are bad and alcohol is just something that happens. When you look at the terrible damage wrought by misuse of alcohol, it's huge, isn't it?
Oh, it is. And there's so much in our kind of everyday culture that kind of, normalizes alcohol use, mummy's little helper, all these kind of memes around, the huge glass of wine at the end. I'm only having one glass and it's a glass as big as a bottle. And that's all very much condoned and laughed and joked about, but not the same for substance use. And, there are... Oh, well, we could have a whole other episodes on kind of why certain drugs are illegal and why others aren't. And no, it's nothing to do with their actual risk profile. If we were to find drugs all over again, I expect alcohol would be, considered one of the riskiest, and something like MDMA one of the safest. So our drug classifications are not done on risk. But yet we kind of see so much about what's okay, what's not okay through that lens, and that will absolutely be the same for our students, and we see that in class all the time. So it's been a big kind of, it's really important to me that we work on this, not only for the things that we talked about today, but perhaps more importantly than anything for me, and trying to be an advocate for the people that I've worked with in the past. Sadly, lots of people who do have problems with drug and alcohol have horrible experience of using healthcare services. Really horrible experiences. Treated very rudely, not seen deserving of care. Really awful things people have told me about that's happened to them, and I've heard them and witnessed them myself actually when I've been with patients. And this is backed up by the literature. There's heaps and heaps of information out there about stigma amongst nurses, and almost any paper you find from anywhere in the world will suggest that the most stigmatized group of people who use health services are drug users. And if that's what is out there in our workforce, the only way it would seem to me that we can start to change that is by changing the message from day one, right from when they start their training. So thinking about how we get substance use addiction into our education systems, to me, the top line of that has to be, how do we reduce stigma?
So
and that feels like the most important thing to me.
On having those kind of conversations then, so obviously they need to go all the way through and across all the fields. And you can't just have, older adults won't deal with this, children won't deal with this, because it's a human issue, not an age-related issue.
Yes.
Not a class-related issue. It affects everybody.
Absolutely.
Certain drugs or experiences maybe go with certain populations more, but it's relevant for everybody.
Yeah, absolutely. And often the substance is irrelevant. You know, it's more about function it's serving for that person. People find what works for them, but it's kind of almost irrelevant. Yes, we might manage it differently from a clinical perspective, but when we think about, you know, why are they doing that? Why do they continue to do this thing that's, you know, causing them lots of harm in lots of ways, yet they're continuing to do it? We need to look beyond what the substance is to really unpick how we work with that.
Absolutely. So, you know, we've talked a little bit about the kind of the stigma. You know, we're talking a little bit about thinking about kind of working more in partnership with people. And obviously, you can't have partnership with someone if you keep calling them an addict to their face, or a substance abuser. Like, just say use of substances or something fairly neutral. You don't have to have these kind of like pejorative language, do you? All the time? But tell me a little bit about, because one of the things you particularly were working on was this responding to overdose, because I think there's a lot of anxiety around that kind of immediate care. What do people need to know about that?
I think so too. So that is a big project that we've undertaken at the University of Bradford. And we started this, our first run was just about a year ago. So we started talking about it probably about 18 months ago. And it really was kind of thinking about all the things we've been talking about today, because we did have some things, I'd been able to get some things into the curriculum. So there was stuff around brief alcohol interventions, how we would use, say, motivational interviewing for conversations around behaviour change. And then we, for the mental health students only, we were bringing in people with lived experience of very severe addiction problems. So the students were having this fantastic experience of working with people who really were able to tell them about drug use and the impact of that in a much more illuminative, impactful way than I ever could. And the students are absolutely mesmerised by the brilliant people who come in and who we work with. And we've worked really hard to kind of cultivate really good relationships with people who were able to come in and share their stories. That's felt like a really important thing. But as you said, I wanted to get something that would have much greater coverage, that went right through our programmes, all our fields, to show relevance for everyone. So linked up with our drug service in Bradford, and they are New Vision, and their parent organisation is Way Through, and they are fantastic. They're a brilliant partner to us at the University of Bradford, and so I just kind of asked them to come around the table with me and see what we might be able to do, how we might be able to pull something together with very little resource other than lots of goodwill, but how we could do something that would really make a difference. So it was great. So I was able to get academics like myself, clinicians from the service, people with lived experience from the service, to get together and say, okay, what can we do? And so we started off with thinking about challenging the myths, the stigma, all that, you know, what things might help us to do that. And we thought, well, okay, why don't we teach the students something really practical that feels very hands-on? Because in our experience, the students love to kind of do something that feels practical. So we said, let's think about putting together a package that looks at responding to overdose. So that's going to be the key message. But we're going to use that to weave in lots of other things too. We're going to use it to weave in this: drug users are normal people, you know, you don't need to be afraid, what's some of the stigma. So we wanted to use the overdose kind of response as the hook, but that kind of, it was almost secondary to me to start with. It was more about how do we embed this, you know, how do we get it right into everything we do. And so the team over there were great, and we were able to come up with a package of training that we plan to roll out to all our first year students. So we they get a great kind of session around what are opiates and a little bit of the background of opiates and something about the opiate market, because it's been really important to us to you may or may not have heard, but we've got a problem, an increasing problem in the UK with nitazines, which are potent synthetic opioids getting into the illicit opiate market. So where people think they might be buying heroin, for example, they're potentially buying a nitazine, which could be up to 500 times stronger than heroin. So we were able to give the students some really kinds of interesting, current, live kind of data about why that is, what we know about it. And the students are really interested in that. So we talk about what's happened in Afghanistan, what have been the changes there, and it really hooks the students in because it feels very current and contemporary. We then go on to talking about looking at what are signs and symptoms of an overdose. How might you recognise if somebody was having an overdose? And so we're thinking about that in lots of different settings. In the hospital setting, in community, when you're a private citizen out and about town, walking around, what might an overdose look like to you? So we have great conversations around that, what signs and symptoms look like, and we try to differentiate that between different populations. And students seem to really enjoy that and really kind of buy into that discussion. And then we talk about how you can respond to an overdose, how you can save a life. And we look at two kind of pathways, really. We look at, well, what does that mean as a student nurse? But then what does that mean as a private individual? Because how you might respond might be different. So we talk to them about basics, about how whatever you're doing, you need to keep that heart pumping, all this kind of stuff. So we'll talk about CPR, but we talk about naloxone. So most of our students, so naloxone is an opiate antidote. And so we talk to them about that. And essentially we train them how to use naloxone. So we train them in two different formats. So one is as an IM injection and the other is administered nasally. And we train them in both of those things. So the students get to do something that's really hands-on. And because it's our first year group, or we started with our first year group, for some of them it was their first time doing an injection. So there was a lot of energy and a lot of excitement in the room. But actually students reported feeling really proud that, you know, they potentially might be able to do something and respond.
You find naloxone all over the place now.
Naloxone is here's my naloxone kit.
Well, I wasn't expecting that.
Yes,
it's everywhere.
Anyone can carry naloxone. If you've had training in how to carry naloxone, you can carry it. And to get training, you can go to your nearest drug service, who will be absolutely delighted to train you in administering naloxone. So this is an IM kit. If you would prefer, you can have the nasal kit. You can pick what you'd like to have, essentially. So we have to be really careful about how we talk to the students about this, because what we don't want them doing is having a take-home naloxone kit and then carrying it on placement and administering it, because that would not be appropriate. So we talk to them about the fact that, you know, medication is medication and the same guidelines apply as administering any other medication in practice. But then we do differentiate and say, but however, as a private individual, there is nothing stopping you, now you've completed this training, carrying take-home naloxone. And we provide all the students who've completed the trainings details to the local drug service, and students can choose confidentially whether they wish to go and obtain a naloxone kit or not. So there's no pressure for them to do that. We've about 50% of students indicate that they intend at the end of the session that they intend to go and collect a kit, because it's very low threshold to obtain one of these. They don't take people's details and things, so we've no actual way of knowing how many people get them. But it's kind of irrelevant to me, because, you know, actually what I want is for students to be able to go out, and when they meet people who might be using opiates, for example, to be able to have a conversation and say, do you know about this thing called naloxone? Do you know where you can get it from? You should get some. And do that kind of signposting. So to me, it really doesn't matter if they get the kit or not. Brilliant if they do. But, you know, the important thing is they still know how to respond, even if they haven't got naloxone. They're going to think about CPR. They're going to think about calling an ambulance, rather than thinking, oh, should I get involved? Should I just walk past? You know, and students students do say often, you know, oh, I've walked past people when I've been walking through Leeds and there's been someone on the floor and I've not known if they were dead or alive, and I've not really known what I should do. So if from that session students go away and just think that person's not moving, I'm going to ring an ambulance, you know, we've achieved what we wanted to achieve.
Yeah. But there's some things, I mean, what is the point of education if it doesn't move people from passive to active?
Yeah.
What's the point of it? And I'm getting some questions for everyone.
Brilliant.
Dave, can we come over to you for the one you have? And I've got a couple of students that have texted in.
Sorry, I've got so many different screens open with all the different social media.
I was just saying, I can see you've got a question.
Yeah, so it's just that bit about talking about training that you mentioned, I think, quite near the start about the need for NHS staff to do basic life support training. And obviously that, you know, you kind of have the regular requirement to do that, don't you? It's not like you've learned it once at university and then you carry it for the rest of your career. I suppose it's that bit about, you know, if we kind of wanted students to learn about overdoses, I suppose what you would say is you have to keep that current information going, don't you? So, you know,
obviously,
that's something you
the converted. In my opinion, wherever there is a defib, there should be one of these within the defib. That is what should happen. So yes, for me, it should be very much part of basic life support, and it should be something that we refresh in to learn to administer this. The drug services train people in about 10 to 15 minutes. It's not difficult. They are designed to be used by members of the public. So in here are pre-filled syringes. The doses are measured. So, you know, it's apart from the fact, obviously, it's challenging in an emergency situation emotionally to do this, but so is doing CPR, you know. But these are designed to be very user friendly. They're not designed to be, you know, healthcare professional only. They are low threshold, easy to handle. So yes, for me, we should refresh absolutely if we have capacity to do so, and that should be often like we do CPR.
And just in terms of that, I know, you know, there's been kind of an explosion of the use of AEDs out in community spaces. You know, if I went outside within a few minutes of my house, you know, they're on a few different street corners, and I suppose there's that bit in there about, you know, them being a very automated thing that, you know, if you phone up 999, they can talk you through how to do it. Is the same kind of process in place for overdoses? Or
it's not in place now. I hope it would develop, because, you know, I think there will be increased lobbying for these naloxone kits to be around AEDs and things like that. And I think should that happen, then yes, I imagine we'll go to a system where, you know, if you ring 999, they're advising you what to do. But there is a leaflet in here that walks you through with pictures exactly what to do. And the great thing about naloxone is it's very hard to do damage with what's in here. So even if there are 5 doses in one pre-filled syringe, but if you whack the whole lot in, you're not going to really hurt somebody at that moment in time. They might come round really, really quickly, but there's going to be no impact. If you use naloxone on somebody who hasn't overdosed, but you thought they had, again, it will do no harm. So minimal kinds of opportunities to do something really dangerous with naloxone compared to other medications that we might use IM.
I think you're almost answering one of the questions that just came through here from somebody who sounds very worried, saying, what if someone's had a heart attack? Can you tell the difference between a heart attack and an overdose? And what if I give them naloxone and they've had a heart attack? They're very fixed on heart attacking. Yeah.
Well, that's understandable, because we talk about it a lot, don't we? Yeah. So you wouldn't harm them if what had happened was that they'd actually had a heart attack. You wouldn't harm them, but it wouldn't reverse the heart attack, is the key message. But the other thing we would say is, you know, if you administer naloxone, we would also be thinking about, do we need to do CPR? Because, you know, we need to get this medication pumping around the body. Okay, so we're going to need to do CPR potentially as well. So that is all covered in the training also, but you're certainly not going to do any damage if you administer naloxone when actually somebody has had a heart attack or any, you know, any other kinds of
I think as well, for the person who's so concerned about a heart attack, if someone has had a heart attack, their heart might not be beating at all, in which case it can't get much worse. Like, give it a bash, I would say, at that stage.
Yeah,
like,
absolutely.
You're not going to make them worse than actually already. So do something rather than nothing. Somebody else is saying, I really want to get a space working in substance misuse, but I can't find anywhere who'll take me. What advice?
Oh, that's such a shame. So I'd say as a starting point, do reach out to your local drug service. In my experience, they are really keen to have students because they desperately need to get more people working in this space. So certainly in my area, I know that they're really keen to have students. The other places where you can perhaps get some experience, there might be inpatient teams in your local hospital. So lots of the drug services will have hospital in-reach teams that you might be able to be part of. Or you could, it's about knowing what's in your area. And so some of the CMHTs, for example, will have nurses who lead on substance use, for example. So it's about finding out who can I tap into, and it will be different in every area. But I definitely start with the drug service. And if they're not able to take you, maybe try the one on in the next town on. I don't know where the person who was asking the question is, but like certainly where we are, you know, we've got maybe 4 or 5 towns that we could access quite easily. So be persistent, keep trying, and because, you know, in my experience, students do have such a fantastic time when they do spend some time with substance use services, and they learn so much so very quickly.
In fact, I think absolutely, if it's your passion, go for it. And also understand what's happening sometimes with nurse education. Sometimes you don't get placements if they don't have someone who can be your placement advisor or practice advisor. So like someone who in the old days would mentor you. So often if you're on a shortened course, like a PG or a master's or something, you've only got a shorter amount of time to fit it in. You need to be being assessed all the time, and so sometimes those options are shut to you. But if you have conversations and if you show passion and interest, somebody will bite your hand off to help you, because it's absolutely exactly what I was saying about finding the right person, someone who's in that space who's able to see how interested you are, and they will sort it out for you. It's most likely a paperwork issue, rather than that drug services don't want any more help.
Absolutely. And the other thing to say is, you know, there are often drug services you will find have lots of voluntary opportunities within them, lots and lots. They're always crying out for volunteers. And certainly if you're a mental health nurse, you know, a student mental health nurse, you've got loads of brilliant skills that you might be able to, you know, help run a group or something like that. And in my experience, drug services are really keen to get volunteers. So that might be worth pursuing as well. And I just wanted to add, because I'd not said it before, but it was really interesting, some of the evaluation that we've done on the sessions that we've delivered at uni. We've got so many students who've said, I'd never thought about a career in substance use services, and now I'm dead keen, like, how do I do this? So, you know, it's just about switching people on to those opportunities, really.
Absolutely. That everybody finds their niche. You just got to really look around and find out what suits you. I can see that we're coming to the end of our time, so I wonder if there's anything that you guys want to add. Dave, is there anything that you wanted to add, or you don't have to? It's not the law.
Good, because there isn't, but it's been really great listening, so I'm going to carry on with
Natalie, is there anything you wanted to add before we finish up tonight?
No, just that, you know, it's been my absolute pleasure to be able to come and speak about this. It is something that is so close to my heart, and you know, I do encourage everybody to think, everyone in academia, to think about what can we do. And if you're listening and you're a student, ask your lecturers, ask your teaching staff, how can we start to think about substance use? What can we do? How can we get involved? Think about going and approaching the drug service to see if you can be trained to carry naloxone. We've now trained all our students at Bradford and Forth, are now trained in overdose response. We've done that in just over a year. So if we can do it, everyone can do it.
On that note, of a load of absolutely furious lecturers grinding their teeth. Let's finish up.
Thank you.
Thank you very much, everyone.